Hello, and welcome to this webinar, which seeks to highlight the recent published Global Health Science and Practice Supplement on TCI's experience scaling up family planning and AYSRH interventions through supported local urban governments. I will provide a general overview of the Challenge Initiative, TCI, and introduce four of my colleagues to share highlights on some of the articles in the supplement, as well as our recent results. After the presentations, we will open up for questions. So let's start with this quick overview of TCI. So the Challenge Initiative was launched in 2016 with a business unusual approach to sustainably scaling high-impact interventions in cities across 4 regional hubs: East Africa, Francophone West Africa, India, and Nigeria, that were proven effective under the Urban Reproductive Health Initiative, URI. URI was a proof of concept family planning program funded by the Gates Foundation in 33 cities in Senegal, Nigeria, Kenya, and India. TCI, however, is a different model than URI in that we do not implement. Instead, we support local governments to implement and scale what worked under URI. This has now evolved to include the global high-impact practices and other interventions. In our first phase, that is between 2016 and 2022, we scaled up to 118 cities. Our next-gen phase, which is now, we're engaged in 201 local governments. TCI is grounded in 4 foundational interlocking tenets: scale, impact, efficiency, and sustainability. At TCI, we believe that scaling without impact is empty scale. In impact at scale without being more efficient is not viable. And efficient impact at scale that is not sustainable will not produce lasting health systems change. TCI aims to deliver on all these 4 tenets, recognizing that one without the other 3 is inadequate to achieving enduring progress. This graphic shows how TCI engages with the local government. It begins with an expression of interest, or what we call EOI, from the city that is interested in TCI. And this EOI is critical because one of TCI's guiding principles is that it is demand-driven. The EOI contains 4 criteria, which is evidence of political commitment, a certain level of health systems readiness that can be built upon, the size of potential population impact, and a pledge of resources to contribute to implementation. After an expression of interest is approved, we work together with the local government staff to develop a program design to implement high-impact practices, HIPs, and other interventions for family planning and AYSRH programs. Coaching then begins at this stage, and it's at a high intensity and what we refer to as the lead stage. And at this stage, our coaches familiarizes the local government staff with TCI University and the high impact practices and other interventions. TCI University, TCIU, is a virtual university without walls that houses regional toolkits with the interventions we've talked about. Before a program design workshop, a landscaping and gap analysis is conducted to reveal the most pressing family planning and/or AYSRH issues to address. At the workshop, TCI coaches provide technical support to help local government staff prioritize their issues and select from TCIU the minimum package of interventions needed in line with the Pareto principle, that is the 80-20 rule. The HIPs and the HIs available in the TCIU addresses issues related to service delivery, demand generation, advocacy, as well as management and coordination of the program itself. At this time, the local government will be asked to make a funding commitment to implement their program while we contribute seed funding from our Challenge Fund. The next stage is implementation, where the local government actively implement the high impact practices and high impact interventions at public health facilities and in the community, while also conducting a number of monitoring and evaluation activities. TCI's coaching, which was at its highest intensity during the program design, tapers down over a period of 3 years from the lead to assist to observe. Once the implementation stage ends, local governments graduate and can then receive coaching on demand. TCI financial support then ends at this point. So now let's get to the crux of today's webinar, which is the GHSP supplement and its overview. The supplement was completed in May 2024, and there are 9 articles that offer new evidence related to TCI's collective experience, best practices, and lessons learned from between the period 2016 to 2021. It also highlights significant progress that has been made in identifying effective family planning strategies encompassing service delivery, social and behavior change, and new contraceptive methods. Despite this progress in family planning programs in general, an evidence to practice gap persists that hinders widespread adoption and scaling of high impact practices and interventions. And then addressing the health needs of marginalized urban populations is critical for achieving sustainable development outcomes, particularly given projected demographic trends. Let's now look at some of the key findings from the family planning interventions. So the findings emphasize the importance of 1, local government ownership, 2, innovative financing models, and 3, integration of family planning services into existing health systems. The various articles also highlight the need for 1, adaptive management, continuous stakeholder engagement, and 3, a strong emphasis on sustainability to ensure interventions can be successfully scaled and maintained in diverse contexts. Now let's look at some of the key findings from AYSRH. So tailored programming is key for addressing specific needs and barriers faced by adolescents and youth. And then comprehensive adolescent and youth-friendly services can enhance contraceptive uptake and improve overall SRH outcomes. Other factors important for success are 1, leveraging existing health systems, engaging the private sector, and lastly, and not the least, ensuring quality improvement processes. So we realize that the role of local leadership is critical. That's local leadership, ownership, and investment is crucial to this approach. Effective advocacy to build consensus among stakeholders and secure sustained finances are pivotal. 3, utilizing existing government and health system structures proven to be highly effective. Then the engagement of influential champions such as religious, traditional, and other high-profile leaders is another critical factor. Data-driven decision-making is key for promoting sustainability. I'll now like to introduce 4 of our colleagues who will be providing highlights on 3 of the articles in the supplement, as well as also highlight our current results. The first speaker, Josephine Nabukera, is the country lead for TCI Uganda, and she'll be speaking on the Uganda Boost. Emily Das the Senior Technical Lead, TCI India, will be the second speaker, and she'll be speaking on first-time parents. The third speaker, Victor Igaru, who is the Regional Hub Manager, Pakistan and Nigeria, will be focusing on Nigeria's co-financing model. And then the last speaker will be Ian Salas, who is a Senior Technical Advisor, and he'll be highlighting the recent results of TCI. So, Josephine, shall we call on you, and please take it away.
Good morning, good afternoon, everyone. Thank you for joining in for this webinar. Thank you for giving us an opportunity to share the Ugandan manuscript that was recently published, titled Boosting Contraceptive Uptake in Urban Uganda. Older women benefit when layering adolescent and youth interventions onto an existing family planning program. Presenting this afternoon, is Dr. Josephine Naukero on behalf of all the co-authors. As a way of background, Uganda has a high unmet need for family planning, with over 28% of currently married women and 32% of sexually active unmarried women, according to the UDHS of 2016. And yet also, Gatmacher Institute 2020 showed that women wanting to avoid pregnancy in low and middle income countries have an unmet need that is much higher for adolescents at 43% compared to the women aged 15 to 49 at 24%. Uganda has a very young population. Over 80% of the population is under the age of 30, and about 25% of Ugandan women aged 15 to 19 have begun childbearing. In Uganda, 52% of pregnancies are unwanted or mistimed, with over 43% of the unintended pregnancies attributed to the high unmet need already highlighted. And yet also we know that uptake of family planning among women of reproductive age is low in Uganda, with an MCPR of 34%, and is much lower among the 15 to 19-year-olds and among the 20 to 24-year-olds. Barriers to family planning use among the adolescents and youth include peer influence, parental barriers, social cultural barriers, and stigma, among others. So we set out a research goal of determining whether layering AYSRH interventions onto an existing and functioning FP program would result in increased contraceptive uptake among two groups. One for the adolescents and youth aged 15 to 24 years, and the second one of the women aged 25 to 29. And we had a program goal of improving contraceptive access to adolescents and youth aged 15 to 24 years within the larger cohort of women aged 15 to 49. Regarding geographic coverage for TCI East Africa in general, we are into 63 cities, 22 for Kenya, 16 for Tanzania, and for Uganda, 21 cities. And particularly for this study, we had 3 cities that we partnered with in Uganda. So the Ministry of Health in Uganda partnered with the Challenge Initiative to implement a multi-pronged approach, layering AYSRH interventions onto a functioning general family planning program for women of reproductive age in 3 locations of Buyikwe, Mukono, and Iganga. I want to take off some time on this slide showing you the comparison between the general family planning program interventions that we had in all the other locations, and then in the 3 locations where we layered AYSRH onto the general family planning program. And these were under 4 domains. 1 of advocacy. For advocacy, we supported the locations to ensure that they increase government allocations towards family planning. In both locations, the family planning program only and those where we layered the AYSRH And particularly for this, we supported the local governments to skew the financial allocations for both family planning and AYSRH interventions. Then in the general family planning program only, we used family planning champions to support that initiative. And yet also for where we layered the AYSRH program in the 3 locations, we had youth champions whom we supported in meaningful youth engagement. At governance level, we used to ensure that we support them to be part of the monthly program implementation team meetings, through which they would then voice their needs and ensure that their needs are addressed. And at community level, we use the peers to support their peers to refer them for AYSRH interventions. And under service delivery for the general family planning program only, we had what we call the whole site orientation related family planning, including commodity and data management. And in this, we orient the location staff regardless of cadre, right from the gate to the mortuary, to ensure that all have family planning information and can therefore ably make inter-facility referrals between the service delivery points to ensure that we do not have a missed opportunity and everybody who needs the family planning actually gets it. And then for the layered program, in addition to the whole site, we also ensured that we orient the staff on the value clarification to reduce the bias towards youth who access contraceptives. We also had 72-hour makeover, which is a health facility strengthening initiative done in the shortest time possible, in 72 hours, to make sure the infrastructure is improved. And in the layered sites, additionally, we used the quality improvement national standards for adolescents and youth-friendly health services to ensure that we have those in place, use the supervisory checklists with specific attention to the health providers' biases, and ensure that that is taken care of and adolescents are able to access the services without bias in the layered locations. And then we also had the integrated family planning outreaches and inreaches. And for outreaches, integrated family planning outreaches, we mean taking services nearer to the people they had to reach and ensure that there are no missed opportunities in the hard to reach. And inreaches is where we take expertise to the lower level facilities to ensure that we support them in the mentorship to gain the skill, especially around long-acting reversible contraceptives, and ensure that at that level, they're able to provide services that all method meets. So for the layered program, we had integrated youth-focused outreaches and inreaches to support the adolescents and youth. Under service delivery still, we also had fixed day services at the facilities. And for the layered program, these were skewed towards the adolescents and youth to ensure that particular days are organized and AYs are mobilized to come and participate and access services. Then we also had postpartum family planning for all women as an intervention. And for the layered program, we skewed ourselves towards the young women, the young mothers, particularly those that were unmarried, and also added a pharmacy engagement. And for Uganda, the AYs access a lot of their reproductive health needs through the pharmacies and drug shops. So we trained the pharmacies and drug shops in short term, but also emphasizing referrals for the long-acting reversible contraceptives. Under demand generation, for us to dispel myths and misconceptions, we trained community health volunteers in the general program. And then in the layered program, we had peers added to the community health volunteers to support their peers in counseling and referrals, but also giving them information around the facilities where we're partnering. Then we also had male engagement initiatives for youth, especially. We had WhatsApp groups that were targeting youth, social mobilization through community events that was targeting youth, as well as radio segments on AYSRH. So then we analyzed service statistics from the Uganda HMIS Health Management Information Systems to assess contraceptive uptake for adolescents and youth aged 10 to 24 and older women aged 25 to 49 before and after implementation of the AYSRH approach in the 3 locations. And among the indicators we assessed, we focused majorly on the net contraceptive uptake. And in this, we mean a derived number of additional modern family planning clients over a particular period of interest, expressed in annualized terms per 100 women of reproductive age. So we collected family planning visits data by location and method from the Uganda HMIS and disaggregated that by age group, the 10 to 24 of interest, the AYs, and then the 25 to 49-year-olds. Then we reviewed the quality of data to address any missing data or outliers and updated as necessary. We also grouped the data sets according to intervention location, whether a location had only general family planning or a location had general family planning and the layering of the adolescents and youth sexual reproductive health, which were only 3 sites. And then we compared with the Uganda General Family Planning Program. So we calculated indicators of interest for each grouped data set, especially the net contraceptive uptake. And the period of analysis was July 2017, June 2018 as our layering time, and then up to July 2020 to June 2021. We analyzed for the net contraceptive uptake trend analysis, and then the NCU difference in difference analysis. Really looking at the FP methods, the pills, the injectables, condoms, emergency contraceptives, implants, IUCDs, and then sterilization. Looking at this graph where we have, sorry about that. We have the blue line graph as the general family planning and the layered AYSRH locations. And then the red looking at the general family planning to women of reproductive age. And the orange line looking at Uganda Family Planning Program. And as you can see, before the TCI implementation, remember we've talked about the period of analysis looking at July 2017, 2018. Already in June 2016, like I mentioned earlier, the TCI program had started implementation in the urban locations, 14 urban locations. But then in 2017, 2018, we started layering with the AYSRH intervention. And as you can see, before the TCI implementation, the data shows NCU of the general family planning only in the local governments as higher than the layered locations, as you can see, compared to the general family planning and AYSRH in the country at large. And among the women aged 25 to 49, as you can see, following the layering, yes, we had the expected, the AY's NCU increased markedly, but importantly, all of interest to us, or what interested us more, was the boost that came through with the general family planning only program in the locations where we did not have a layering. And all of these, both of these were definitely much higher than the general country family planning program. And yet, of course, when you look at the adolescents for whom we said, let's layer the AYSRH interventions onto the general functioning FP program and see what this will result into, of course, we had a spike, a huge jump into the uptake, the net contraceptive uptake among the 10 to 24-year-olds, as you can see. But like I said earlier, in the earlier slide that was focusing on the older women, 25 years and above, we really had such a boost in their uptake. So generally, after TCI implementation, the net contraceptive uptake for both adolescents and youth aged 10 to 24, the spike that we're seeing, and women aged 25 to 49 was higher in the general FP and AYSRH local governments than in the both FP and the country at large. In essence, what we're saying, we want to conclude by saying, from what we have seen in the results slides, the layering of TCI's AYSRH interventions onto a well-functioning family planning program increased contraceptive uptake among adolescents and youth aged 10 to 24 years old, as well as boosted an uptake among women older than 25 years. So allow me to stop here, and thank you very much for listening to me. Over to you, moderator.
Thank you, Josephine. Shall we now call on Emily? Emily, please take it away.
Greetings, everybody. I also want to welcome everyone once again on this webinar. I'm going to present the learnings from one of the manuscripts published in GHSP from India. That manuscript is titled as Engaging Community Health Workers to Enhance Modern Contraceptive Uptake Among First-Time Parents in 5 pilot cities of Uttar Pradesh. So before starting the presentation on this manuscript, I wish to thank all the authors. The first author, Mr. Mukesh Kumar Sharma, Executive Director, PSI India, who was instrumental in designing the program and laid the entire process of study conception, design, and data collection, and encouraged to publish this in a peer-reviewed journal. I also want to thank Hitesh Sahni, who is the current Chief of Party of TCI program in India, to co-lead the implementation of this program, and Kate Graham, who is the Hub liaison in India, supported at each course of implementation as well as publication. I also wish to thank other co-authors of this article, Jessica Mirano from Gates Institute, Abhishek Kumar from Population Council Consulting, and Clea for their support in review and interpretation of results and approve the final version of this article. So why first-time parents? Traditionally, if we look at the family planning and reproductive health programs of Government of India, that program has actually focused on all married women belonging to 15 to 49 years and inadvertently neglected the married young first-time parents. Despite this group's enormous unmet need for family planning, that is around, recent data shows around 21% among first-time parents, those who are resident between 15 to 24 years, versus 9% among the women, those who are 15 to 49 years. So young newly married women and FTPs are presented by gender social norms to have early and closely spaced repeated births to prove their fertility and values in the society and in the family. So the vulnerabilities and social exclusion of FTPs are even further heightened when it comes to the women, those who are living in the urban poor settlements like slums. We know that urban poor, they do have their high fertility, low use of health services, poor maternal health outcomes, and therefore low contraceptive use. So since the launch of India's family planning program, the program exclusively focused on permanent method, especially with an aim of controlling population. So if you look at the recent data in Uttar Pradesh, women adopt female sterilization only after having an average of 3 to 3.5 children. So hence the unmet need for spacing pregnancies is higher uh, uh, among FTPs than the unmet need for limiting. So therefore, if given an opportunity, FTPs are likely to adopt the short-term and reversible methods of contraception uh, rather than permanent method. And this has really been, promoted recently by Government of India. So taking this opportunity, PSI India, through its TCI program, actually implemented a AYSRH intervention into the existing service delivery model. So this program is supported by National Health Mission and with financial support from Gates Institute. In August 2018, we layered AYSRH program into the existing service delivery model and tested it in 5 pilot cities, especially in Uttar Pradesh, in terms of to deliver the services to the young first-time parents by strengthening the urban local governments, health providers at UPHCs, community health workers like ASHAs, and advocated with the local government on releasing incentives such as especially for the ESP scheme. So this is the scope steps of the approach that was implemented for first-time parents in terms of making the data visible, coaching and mentoring ASHAs on various in various sessions, at least in this area. 6 sessions were actually planned for us as starting from their coaching on mapping listing, how to update the urban health index registers where they record all the births and then identify the first-time parents, sensitizing the influencers, especially the family members, those who can actually influence the first-time parents, whole site orientation at the facilities to make them, to remove their bias and make that facility adolescent friendly. So if we look at the interventions package that was demonstrated in pilot and a comparable sample as called as non-pilot cities, then these are actually the interventions in terms of focusing FP services for 15 to 24 years, coaching the ASHAs for FTPs 15 to 24 years, supported ASHAs for ESP, establishing adolescent-friendly health services, training at least 1 providers from each of the UPLCs on adolescent and youth-friendly services, whereas in non-pilot cities where these interventions, this intensive FTP interventions not implemented, we just have, a kind of focused day of FTP services for all married women 15 to 49 years, and coaching of ASHAs to update their UHIRs again for 15 to 49 years. So coming to the data and methods that we have used for this paper, we actually analyzed the data from an output tracking survey, which is a cross-sectional survey conducted in September 2019, just 1 year after the implementation of the program. The survey adopted a multi-stage stratified random sampling design to select currently married women 15 to 24 years in slum areas, resulted into 549 first-time parents included in the sample. And for non-pilot, a comparison group of FTPs were drawn from a main survey that was conducted for the entire geographies where TCI program implemented, after excluding the responses for the women, those who were above 25 years, especially for the 25 to 49 years women. So the FTPs were living in slum areas and did not receive any FTP interventions, but these FTPs of non-pilot cities are exposed to the government-led general family planning program. So in both the geographies, the tool deployed was uniform. If you look at the analytical framework in which this paper analyzed the data from OTS, we dealt with three different variables. The confounding and background variables in terms of age, education, number of children, marital duration, religion, caste, employment status, and wealth index. And then in terms of the program exposure, we actually created three exposure where first-time parents belonging to 15 to 24 years are actually exposed to FP information in last 6 months of the survey. So we defined three exposure in terms of exposure to FP information through ASHAs, exposure to FP information at service delivery points, and any exposure either through ASHAs or service delivery points. So when we're talking of service delivery point, we are actually included, women visiting to an urban primary health center or outreach camp or, urban health and nutrition days. And the dependent variable that we have seen is, use of modern contraceptive methods among first-time parents 15 to 24 years. And we have used univariate, bivariate, and multivariate binary logistic regression to see the association between information exposure and modern contraceptive use in pilot and non-pilot cities. So coming to the results, if you look at the sample between pilot and non-pilot, the demographic and the socioeconomic characteristics are almost similar, except a slight difference in the wealth status. So in terms of the exposure between pilot and non-pilot cities, exposure to FP information through ASHAs is higher among FTPs and pilot cities, which is around 51% compared to 32% in non-pilot cities. In contrast, exposure to FP information through the service delivery points is higher among FTPs in non-pilot cities compared to pilot cities. So this might be possible because the greater reach of the ASHAs among FTPs and pilot cities, where they provided FP-related information by making the home visits to these FTPs, and for which that probably minimized women's need to visit to a service delivery points. That needs to be validated through through a different round of population-based survey. So coming to the next result in terms of whether this program exposure is actually playing a role in terms of improving the contraceptive use among the first-time parents, we're actually seeing a very striking results. Overall, the contraceptive use was around 39% FTPs, 39% among FTPs in pilot cities, compared to the 32% among FTPs in non-pilot cities. So this difference is statistically significant. If we look at by exposure through ASHAs and exposure to STPs, again in pilot cities, the uses of modern contraceptive is higher among FTPs in pilot cities, which is around 41% through the exposure when they're exposed through ASHAs, and similarly 43.8% when they were exposed through service delivery points. So this is really very exciting. So the results that you're seeing, and blue is actually statistically significant through the results, and the black one are not statistically significant. We have run three models to show the results through the logistic regression to see the interaction between CT type and exposure to FP information, and that indicates the contraceptive use is higher among FTPs and pilot cities who are exposed to FP information compared to the other group. Model 1, like compared to the FTPs in non-pilot cities who were not exposed to the FP information through AYSRH, the odds ratio of modern contraceptive use is 1.61 among FTPs in pilot cities who were exposed to FP information through AYSRH. Similarly, Model 2 is actually swaying the results through the exposure to STP, where we are seeing that in comparison to FTPs in non-pilot cities who did not visit to service delivery point, the odds ratio of modern method is actually 1.84% in the pilot cities who visited STP for family planning. Model 3 is even stronger. The association is actually showing stronger when FTPs were exposed to FP information through AYSRH as well as through STPs. The odds of contraceptive use is 1.90 among the women in pilot cities who are exposed to FP information through AYSRH and STPs. So what exactly these results are actually showing this finding of our study align with some of the previous studies like Prashar related to behavior change theory and reinforce the existing evidence that suggests engaging with the government-led community health workers can improve contraceptive use. So these are some of the lessons learned, basically focusing more on the coaching of ASHAs for updating the UHIR, bringing FTPs into the service location, and publicizing the ESB scheme through various meetings, coaching, training, and positioning this scheme as an ASHA investment plan. In terms of implications, these findings have important implications for the design and scalability of future programming for young first-time parents in India. Great uptake of modern contraceptive among young women may be achieved actually when an intentional focus on FTPs is added to the functional FP program. So what we are talking in terms of scalability is government must continue sponsoring the ESB scheme, promote the long-term investment for CHW, allocate funding and resources to build the capacity of health workforce, including ASHAs, for addressing the issues that actually prohibit access to the full range of contraceptive services in the public health system. So in order to mitigate some of these major challenges, the policymakers should strengthen in terms of improving the health information system and also establish a culture of prioritization to review the family planning data, especially for the young married women. So lastly, we want to thank you. I give to the entire TCI program and National Health Mission Government of Uttar Pradesh who supported the design and implementation of this program. We celebrate Asha's success and every young mother's success on adopting family planning method on her choice. The work we showcase today is the hard work and passion of over 1,000 Ashas and 1,000 and more than 1,000 UPHC staff from across 5 pilot cities under the leadership of Chief Medical Officer. We also want to thank the data collectors as well as the study participants from the OTS survey for which these results are actually giving a positive scalability approach to scale it in India. Thank you so much.
Thank you, Emily. Shall we now invite Victor? Victor, please take it away.
Yeah, so today I'm going to be talking about a paper we published titled Innovations in Public Financing for Family Planning at Subnational Level. This paper was drawn from our Sustainable Co-Financing Strategy for Family Planning that we documented with Nigerian states. And I'm happy to have published this paper with my other colleagues and co-authors. So first, I think it's really just to establish the fact that the idea around our co-financing strategy was built around, global trends, one of which is increasing health financing pressure and that is compounded by donor fatigue that is being experienced globally. And so countries are beginning to think creatively around how to promote self-reliance and program sustainability with the right blend of financing. Secondly, we see that this global decline in funding, is affecting the low and middle income countries the most, in terms of how they are able to work within their fiscal space and harness financing options. So there is a more need for innovation around public financing for health programs. After looking at several literature, we came to the conclusion that successful financing models are those that actually allocate and sustain scarce financial resources. It's not enough to allocate. We're also looking at what can be sustained. Secondly, is that successful financing models should be able to use existing resources to catalyze and unlock new resources, and also visibility for innovative financing is very key in being able to unlock new resources as well as build trust and confidence amongst a pool of existing donors. And so the co-financing strategy that TCI developed, is actually built within our core mantra, which is our core aim of supporting countries is to build their management and leadership capacity, to lead, drive, and implement their own health programs. And while doing this, we ensure that they have not just operational autonomy, but also financial autonomy to drive self-reliance, in their programs. And our co-financing strategy is built around three key premises. One is that we thought to develop a co-financing mechanism that is graduated in a way that creates an opportunity for the local government to build its financial sustainability mechanism in a way that allows for it to cultivate self-reliance. And so we also recognize that financing doesn't happen in isolation. We often think that if there's a problem and you throw money at it, the problem goes away, but that is not always the case, in terms of global health programs, that there are many layers that needs to be approached, and these can only be approached from a standpoint of a strong policy program advocacy. So this is built into the concept of our co-financing, and the purpose of this is to build ownership and health systems resilience. Then thirdly is that we thought that it's also important to build leadership and management capability, so that this mechanism and the strategy and the models, for co-financing can be institutionalized, and more so, it is made available in a more transparent and accountable manner, and it contributes to good governance. And so what did we do about the co-financing? First is that we established certain preconditions that must be met in terms of how cities can tap into the co-financing model. First is that we established that fundamentally, many state governments in Nigeria have some key problems with financing. One is that they lack a budget line, and without a budget line, you cannot get funds allocated and released. The second is that even for those with a budget line, may not have sufficient resources allocated. And of course, when the funds are allocated and released, we also want to be sure that they are used for the purpose for which those funds are actually allocated. So our model proposes two main prerequisites. One is that government must commit to contributing an increasing share of the cost of delivering this program. So it's not just enough to say we are putting X amount of resources on the table. They have to commit that they are willing to increase those resources as time goes on. Then secondly is that they must be willing to apply themselves, to our adaptive leadership framework, which allows them to lead implementation even after our support is over. And so this ensures that not only is financing sustained, but the program impact is also sustained. So how does the co-financing model work? This schema sort of summarizes how the financing from TCI, what we call the challenge fund, how it also works alongside the domestic financing harnessed from the state counterparts. So typically, the TCI partnership runs through about a 3.5-year period. And during this 3.5-year period, our engagement is classified into different phase gates, from startup to scale up to surge, pre-graduation, and then those stage graduates. So in the first period, which is startup, which is about 6 months average, we really do not expect a lot of commitment in terms of financing. The reason is that this is where the building blocks, and all the fundamental pillars of sustainable financing is built. This is where the advocacy mechanisms and the frameworks are established. This is where advocacy for budget line and all of that is intensified. However, in the first year of implementation, where we call the scale-up phase, it is expected that the domestic financing makes up to 25% of the total pool of resources, that is created for family planning. And this pool of resources is in matching the TCI Challenge Fund. So technically, TCI Challenge Fund is 75% of the pool. TCI Challenge Fund or other forms of funding should make up 75% of the pool, while domestic financing from government should make up about 25%. And so as you go to the surge phase, it's expected that the portion of government funding should increase to about 33%, while at the point where it is getting ready to graduate, what we call pre-graduation phase, it should increase to about 50%. And so the expectation really is that beyond graduation, if we are able to get government to increase its counterparts to up to 50%, and if it's also able to cultivate some leadership, adaptive leadership principles, one of which is, capacity of policymakers are built, to ensure that fund is committed and allocated. Second is that the health system has been capacitated to be able to facilitate the fund releases. And third is that the pool of coaches that are available within those states or those geographies are able to sustain and allocate resources to drive implementation. The expectation is that after graduation, with the right resources and with the right leadership, we should see a robust governance and accountability mechanism for family planning. Second is that we expect to see some level of self-reliance in terms of how the government is allocating resources to implement its high-impact family planning programs. And also, we expect that locations that actually do very well in terms of finance and also adaptive leadership become a center of excellence and a learning hub for other locations to come learn from. And so I think it's also important to just mention that we have a very robust performance incentive framework that has been built into this model. It's not just enough to say we expect government to bring this and expect we are going to bring this. The question is, how do we know or how do we reward geographies that seem to do better than others? And so we came up with this framework. First of all is that our partnership is reviewed every year at the end of every year. And sometimes we look at different geographies in different states. Of course, bearing in mind that the contexts are different, and we also bear in mind that the different states come into the partnership at different times. So it's really not about comparing states, but meeting them where they are and understanding the dynamics within those locations so that they align within the framework that has been developed. Then, of course, we have two major trackers. One is that we look at implementation progress. We have a tracker that looks at implementation progress, and this happens, on a more routine basis, like monthly. We also look at the spend, government spend versus the budget. We also look at, amounts released by even other partners or resources unlocked, through other mechanisms like intervention funds and all of that. Then on the other hand, we also look at the grant performance tracker, and this is done more on the annual basis. And really the essence of looking at the grant performance tracker is that on one hand, when we are looking at the government releases, we're also looking at how government is able to harness the TCI Challenge Fund. And so we look at, based on the activities that have been planned, how much of those activities have been completed, how those activities lead to the expected program output, and also how, does the partnership fit within the response to the partnership, how does it fit within the expectations in terms of financial commitment made by the partners. So it's on the basis of this that every year the matching fund, which is the absolute amount, is recalibrated and determined, and then the reward to different locations based on how they exceed expectations is determined and allocated, and that's what we call the accrued reward. So this is the performance incentive framework that we implement. So in summary, what have we learned so far, in terms of deploying this model in Nigeria? First is that the model has been very successful, definitely in terms of creating a framework by which financing between donors, government, and even other development partners can be made, can be optimized, and also creating more visibility for it. We have seen that almost all the states, I think as at 2022, we had about 90% of the states had budget line. States that were being supported had budget line for family planning, and those budget lines were funded with commitments, and they were funded. And we are also seeing increased community action in relation to family planning funding. For about the space of 4 years, that this model has been implemented. 13 states that were assessed from beginning to the end within a 4-year period experienced significant increments, improvements in terms of their financial commitment. And within this 4-year period, we had a fund release of about 79%, of committed resources. What this means is that what government committed versus what they actually spent, about 79% of those commitments were actually spent, which is quite impressive in terms of government commitment for family planning. We've also seen that the co-financing model, although very competitive, but it also helps to strengthen government accountability and responsiveness to domestic financing for health programs. And more importantly, this model has been very helpful in also building government capacity and building the capacity of other partners and civil society that are involved in financing for health or financing for health FP. That's really helped them in institutionalizing FP into routine processes. So now we are beginning to see that family planning is part of the annual operational plans. We are seeing more visibility in terms of how funding flows, within the health allocation and how it is distributed, and FP is getting more visibility within, that architecture. So that is pretty much the experience, from implementing the co-financing model in Nigeria. And we have a robust document called the co-financing strategy that has been published, on the TCI University. You can access this document in the link. We also published our first report called the Meet the Challenge Report in 2020, which shows how the different states that were being supported at the time, performed in this regard. Hopefully, subsequent reports will provide an update in terms of how those states are doing currently. And that's about the experience from this paper. Thank you.
Thank you, Victor. We'd now like to invite Ian. Ian, over to you. Ian will be sharing our current results and also wrap up.
Good morning, good afternoon, good evening to everyone. In this final segment of the webinar, I am happy to share with you some updates on TCI's recent activities and progress. The articles for the GHSP supplement were put together in 2020 to 2021. Since that time, TCI has evolved its platform and strengthened its model into what we call TCI Next Gen, So that's the short for the next generation of TCI. These enhancements incorporate recommendations from an external program review conducted by Mathematica in 2021, also our ongoing monitoring, learning, and evaluation partnership with ITAD, and of course TCI's collective learnings over time, supporting over 200 cities in scaling high-impact practices and interventions. Here are the key refinements for TCI Next Gen. We engage cities in 3 additional countries. That's from Pakistan, the Philippines, and Togo. We aligned TCI-supported interventions with globally recognized family planning high-impact practices. They're called HIPs for short. We identified core intervention packages tailored to different country contexts, which also integrated a gender lens. We improved our metrics for tracking trends in contraceptive uptake. We also developed and deployed new monitoring tools to assess the effectiveness of HIPs scale-up and the health system building blocks for family planning. And last here that we outlined is we organized our structure to ensure a more complementary distribution of duties between headquarters and hub implementing partners. We also developed a results framework for Next Gen that clarifies our objectives. Our focus is on coaching local governments to enhance 3 dimensions of HIPs scale-up. That is, increasing intervention coverage, improving implementation quality, and integrating the interventions into local policies and practices. This leads to increased voluntary uptake of modern contraceptive methods, which is our primary outcome 1. Now, the coaching provided by TCI aims to improve local governments' self-reliance in scaling up the HIPs, our primary outcome 2. This is demonstrated through improvements in several health system building blocks, which include implementation capacity, leadership and ownership, local spending, HMIS reporting quality, and use of data for decision making. Lastly, we strive for TCI to be more efficient in its operations, which is our primary outcome 3. We have identified specific activities to achieve this, and they are listed here. So 4 years have now passed since TCI NextGen started. At this point, what do the indicators say about TCI's progress? First and foremost, based on our monitoring of HMIS data until March 2024, TCI-supported cities, in the aggregate, they have added nearly 4.5 million additional clients since their partnership with TCI began. More than half of this increase was actually recorded during the TCI NextGen phase. Let's now examine changes in key indicators related to scale, impact, efficiency, and sustainability. Since middle of 2020, TCI's footprint has expanded significantly, growing from 94 cities in 10 countries with a combined population of 105 million to having 198 cities in 13 countries with a population of 241 million by the end of 2023. Although not shown here, HIPs scale-up is occurring in each of these cities. In terms of overall impact, we saw continued increase in additional family planning clients, as I earlier noted. Now, in terms of efficiency, we estimate that TCI's unit cost has dropped by half, from $37 per additional client in mid-2020 to about $18 at the end of 2023. Other efficiency markers reflect similar improvements. Our monthly cost per city has decreased substantially from $20,500 to $6,400, and the number of staff deployed per city has gone down as well from 1.6 to 1. We also documented that TCI-supported cities were effectively utilizing the funds they committed to family planning, with spending increasing from 70% in mid-2020 to 85% in 2023, which almost everyone agrees augurs well, right, for sustainability. Consistent with this, when we reviewed the HMI's data from graduated cities, about 85% of them are continuing to see additions in number of family planning clients. The overall numbers you just saw provide a high-level overview of TCI's performance. We of course also review performance data at the city level. This screenshot of TCI's dashboard illustrates the detailed scale-up status of various high-impact practices and interventions, as well as health system strengthening efforts. It is worth highlighting that access to near real-time data is crucial for TCI such as this. This kind of access to near real-time data has enabled TCI to detect emerging trends and take timely corrective action when necessary. To bolster this, TCI has made significant investments in monitoring tools under NextGen. We highlight 5 of these innovations here. We have refined the algorithm that we apply to HMIS data to calculate net contraceptive uptake. We have high HIP records to track the coverage and institutionalization of the different interventions. We have what we also call high HIP checklists to monitor the quality of implementation of the interventions, and HSS checklists to track processes and outcomes related to health system strengthening. Finally, in this list, we have a self-reliance scorecard to predict the sustainability of interventions beyond active engagement with TCI. We believe these tools can benefit other large-scale family planning initiatives, and we look forward to future opportunities to share more about them and, of course, our experiences in using them for decision-making. That ends my presentation. Thank you for your interest in hearing about TCI's more recent work. Now I'm turning it back over to Kojo.
Thank you all. Thanks to our 4 presenters. Also, there have been actually questions coming through the Q&A, and we have been responding to some of them. So I think we can, please, if you have any question, if you can put it out in the chat, and we'll be happy to answer it live here. So I think there's one question on the co-financing, Victor, that you can respond to directly here. So the question was from Wanda Soin from Ethiopia, and is, how did you see the effect of boss's individual decision on the application of co-financing? Victor, is this something you want to take?
That's a very, very good question. So one thing that we actually took out from this experience while implementing the co-financing strategy is the fact that context matters, right? So different cities implement the model in different ways, and you cannot really separate the politics and the personal interests that usually is associated with public financing. You can't separate that from how the model will perform in specific locations. So I think it's really important that, in your stakeholder, when applying this model, stakeholder mapping has to be considered, and the interests of all the stakeholders have to be incorporated in how the co-financing model is contextualized for every specific city. Yeah.
Right. Thanks, Victor, for that. So we still do have a few minutes for questions. You probably might not be able to open your mic, but please type in any question. I'm just going to read some of the reactions here, in the chat box as we look out for questions. So Ruth just wrote that great presentations and great lessons highlighted from TCI. Ibrahim also saying nice presentation, clear, precise, and concise. I'm looking out to see whether some more comments. So Ernesto Garilao from Philippines, okay, had put in a question but was responded to by Victor. Thanks, Ernesto. Let me take this opportunity to say a big thank you to all the authors of this supplement. I know it was a long journey, and thanks to also the GHSP staff for guiding us through this. And TCI looks forward to coming up with another supplement of this kind as we get more results coming out. So continue to look out for publications like these. And I also like to say a big thank you to you all participants for joining us here. I think at the highest, we had a little over 215 participants on. Thank you all for joining us here and to hear about it. But of course, you just heard only 3 of the articles or summaries of the 3 of the 9 articles. So to have access to the other publications under this supplement, please go to TCI's website, which is tciurbanhealth.org, and click on publications, which will be under news, to get access to all the other publications, 9 in all. So we highly recommend that you get to see all those 9 publications. And do get onto the publications that are on the TCI website. There's a whole lot of information there. We also encourage you to pay a visit to TCI University. Again, lots of codified materials, high impact practices and high impact interventions. And please feel free to be a part of the community of practice on TCI University, such that we can exchange some of the learnings. So I think with that, it will be safe to bring this webinar to an end. And we look forward to you joining us in subsequent webinars that TCI will be putting out there as we continue to share our work. Thanks for the team that organized the webinar, and thanks to you all, and have a great day, great evening, wherever you are. Thank you.